Hi, this is Dr. Bob Dannenhoffer, Public Health Officer for Douglas County, with another of our Facebook Live events tonight. A little different tonight. There's new rules in Oregon about using masks. The new rules are that if you're in the room with anybody else, you need to leave the mask on. Well, previously we had a camera person here and some other people here, which meant that I'd have to leave the mask on the whole time, which would make it really hard for people who are lip reading. So they're going to be in a different room today, and I'm all by myself, so I can take my mask down. They're going to send me these messages electronically. Who knows how it's going to go today, but we'll give it our best. Again, this is your chance to ask questions. And there are a lot of questions out there. Boy, every day I'm getting peppered with questions. I know it was Sunday, but on Sunday I must have gotten 20 calls from different people, educators, legislators, and others, wondering about what in the world is going on here. And I try to give them my best advice. Now, it's not always good advice, but it's my best advice that I can give. So again, if you have questions, you get a chance to get them answered tonight. Send them in, and somehow electronically they'll show up on my screen here, and then I'll try and answer them. It may not work perfectly tonight, so give us a little bit of slack. Okay, so as we always do, we start at the top of the world and then move down. Still an incredibly active pandemic, 40 million cases, 1.1 million deaths, 400,000 cases in one day over the weekend. You know, until September the 4th, we'd never had a day with 300,000 cases in the world. And now almost every day is 300,000 cases. We're not done with the day yet today, and we're already at almost 400,000 cases. So a very active pandemic around the world. And as much as we think we can kind of keep it contained to Douglas County, we can't. You know, there is going to be travel, there is going to be commerce, and until this disease is tamped down in the whole world, it's going to continue to be a threat. Throughout the world, India, the US, Brazil, kind of all of South America, and then Europe are really seeing lots and lots of disease. So France had actually a higher case rate or per 100,000 than did the United States. The death rate in those areas is still pretty low, but still it's worrisome. But it's remarkably quiet still in New Zealand, Australia, South Korea, and Taiwan. So when I looked at Australia, the 25 million people, that had 8 cases. China has 1.5 billion people, had 13 cases. I'm not sure you can always believe the Chinese data, but I think you can believe the New Zealand data. 3 cases and 5 million people. South Korea had 91 cases, but they've got like 50 million people. Taiwan had no cases. Hong Kong had 4 cases. So as much as we think, oh, there's nothing we can do, there really is something we can do. These are other countries really remarkably like the U.S. You know, so I've gotten a chance to visit China. I've gotten a chance to visit South Korea. I've gotten a chance to visit Taiwan many years ago. And the United States really has many advantages over these countries. So it's not undoable. I mean, there's some diseases that are impossible to control, like measles, and nobody tries. But this one does seem to be one that we could control with enough effort. The U.S., we're at 8.4 million cases. We hit 225,000 deaths today, using one of the measures, 220 by using the Johns Hopkins. Still very active in Illinois, Tennessee, Texas, Florida, North Carolina, California, and Wisconsin. And when I look today, 23 states over 1,000 cases a day. Yikes. In Oregon, we're about, we'll probably hit 40,000 cases this week. 620 deaths. We are clearly in a third wave. So when you look at this graph here of the dates of the cases, we had clearly a first short peak in March and April, a second peak over the summertime, and now a very definitive peak that's going up. I think through the rest of the country, we're also seeing this third peak. And this is a worry, because you remember a month ago I was worried about Israel, which I said is about a month ahead of us, and they had a really short peak in the beginning of September. And my concern is that we would have a big peak in the middle of October, and it seems to be coming true. In Douglas County, we had 10 cases today. Now, these 10 cases come from all over. They come from multiple outbreaks. We've got a nursing home outbreak. We've got a long-term care facility outbreak. We've got a school outbreak. We've got a restaurant outbreak. We've got multiple other businesses with outbreaks. So we're really starting to see so many cases all over the county that it's being hard to track them down. So one of the cases started with a gathering of 30 people, an indoor gathering of 30 people with guests from around the county and from Utah, which is having an enormous outbreak. So you bring people in from another state, you have a big gathering for a few hours. It is not a shock that some of those are going to be super spreader events, and then everybody's going to get sick. And then it moves from businesses to schools to childcare to the hospital, and it gets so hard to control. So if we are going to get this under control, we really need to reconsider travel, and we really need to reconsider gatherings. The increase in the mask requirements is because we haven't been doing the other things, and one of the few things that the government can enforce is a mask mandate. So Chelsea says, we'll see how this goes here, and it seems to be working well. Chelsea says, I'm in quarantine right now. Test was Saturday, sent in Monday. How long is testing to get back? So depending where you get the test done, it's anywhere from 2 to 5 days or so. But again, the testing doesn't get you out of quarantine. So you can have a negative test if you're supposed to be in quarantine till a certain date. You still need to stay in quarantine because a negative test means you're negative at that point. It doesn't say that you won't get positive the next day or that it's not a false negative. So if you're in quarantine, unfortunately, you need to do a quarantine until the quarantine is over. Charlotte asks, where can you get a senior flu shot? So senior flu shots are a higher dose flu shot that some people recommend for seniors. Again, the CDC and the Council on Immunization Practices think that the best flu shot you get is the one that you get. Some recommend the senior flu shot. The pharmacies have that, and many of the doctors who take care of many older people in town have them. So Heather says, has the flu shown up yet? Are they going to be reported in the same years as the past? I haven't heard it yet. There are just a very few cases in Oregon. A case of influenza about 10 days ago. We've not seen a lot of it yet, but if you're a flu nerd like I am, so before I was a COVID nerd, I was a flu nerd, and there's a thing called flu bite, B-I-T-E-S, flu bites, and you can get that from the state or from the feds, and you can go ahead and see. Next question, Crystal says, a student at my son's cohort at Douglas High School tested positive. My son is out until 11/2. So we just found out about that case today, and we're just trying to figure out what the incubation period is. And so it may not be quite as long as 11/2. Public Health said that they were not at school during the incubation period and was low risk. Again, we just got this information at 4 o'clock today, so we're having to sort this out to figure out what the times are. But if you were in the same cohort as the student who has since tested positive, you should stay home from 14 days after the last contact. Again, we think it's relatively low risk. What we've seen in other outbreaks and what other places have seen in outbreaks is that when kids bring it to school, they usually get it from home, bring it to school, but then don't spread it much at school. So again, we think the risk to other kids at school is relatively low. The third question is, do I send my other child to grade school or do I need to stay home from work? So the other child would be a contact of a contact, and they do not necessarily need to stay home. Now, you may need to stay home to take care of you, to watch over your son while they're in quarantine, and there are provisions for that. But as a contact of a contact, you don't need to. So Beverly says, can we get a drive-up flu shot clinic set up in Reedsport? Please, Beverly. So Beverly, you need to send me a note because there was an ask about that, and I said, sure, we could try. But then I never heard back from the person who was supposed to do that. So let me write this down, and I'll remember to do that. But if you could get somebody official, Beverly, to talk to me about this, the mayor or whatever else, I'll write down Reedsport Flu Clinic. Yeah, we could probably do that. We're doing one in Drain this weekend. We did one at the fairgrounds last Friday. There's one up in Drain this weekend. There's another one at the fairgrounds next Friday, Friday the 30th. There's one at the fairgrounds on November 11th. So there's lots of places to do that. So so Shelby says, what do you feel that other successful countries are doing right now to get and keep their numbers so low? Well, most of these places benefit because they are islands, so Australia, New Zealand, Taiwan. Hong Kong's not exactly an island, but it actually operates like an island. And so they were able to do very effective quarantine on entry. So that actually is a strategy that works. Quarantine on entry means that if you're coming from somewhere else, you need to quarantine for 2 weeks before you come in. I think people have confused that with the travel bans that the U.S. used. So travel bans are after a certain date, people from a certain country can't get here. Quarantine on entry means you get here and then you need to quarantine for 2 weeks and then you can do what you do. Quarantine on entry has been the most effective thing that you could do. And so New Zealand has done it very strenuously. Australia has done it very strenuously. Actually, in this country, Hawaii has done it moderately strenuously. They haven't been quite as good as those other areas, and they were all able to keep the shots, the rate very, very low. So I think this is important. So the other thing that they've done is they've done a lot of contact tracing where they find people who've had it. They've had not a lot of political stuff involved in wearing masks and contact tracing, whatever. So the country as a whole has kind of gotten together to go ahead and make this work. The other thing that they've done is they've done a lot of testing. So we just have this Binax testing now here in the United States. They had this in South Korea in March. And so we're about 7 months behind them in this testing, and this testing is really going to help. Rick says, I'm working on a national convention to be held locally in June 2021. Would I recommend canceling? Well, June 2021, I think, is going to be maybe the earliest time that we'll get past this, because by June 2021, I think 4 things will have happened. One is, I think we'll likely to have 1 or more vaccines by then and be able to distribute it. The second thing will happen is I think that some of the promising therapies, monoclonal antibodies or one of those, is going to break out and be shown to be really good, which will mean then that the risk if you get this is lower, which will mean we can be less concerned. The third is that more people will have it over the winter and may develop some immunity to it. And the fourth thing is, I do think this got worse over the summer, not related to this, but I think it's going to get much worse over this winter when the weather gets cold, but then may get a little bit better as the weather warms up in April. So I think for those 4 reasons, June 2021 is the earliest I see that things are getting better. Now, if you need a lot of other planning, I'd wait until 2022. So someone says, if somebody tests positive for antibodies, do they go on any lists? I don't know if there are any lists. We do record all positive antibody tests. So all positive antibody tests are recorded, so if we ever wanted to look them up, we could. But in terms on any lists like cases or whatever, it doesn't get counted that way. Now, remarkably, we've not seen a lot of positive antibody tests lately. I don't think many people are doing those. So what are your thoughts on indoor churches that distance and wear masks? Well, churches are clearly a risk. We know that there have been a lot of outbreaks at churches. But we think you can decrease the risk by distancing and wearing masks. Singing and chanting at churches also seems to be a risk. And so that if you have a church that's not doing that and has distancing and masks, it's as safe as it can be. But again, we do know that in large groups, there's always a risk of a super spreader event. But if you distance and wear masks and don't do a lot of singing or shouting, it's reasonably safe. So Chelsea says, is brain fog a symptom? It is definitely a symptom reported by lots of people. Now, brain fog is reported with lots of things. People get chemo, people who have had open heart surgery and have been on bypass. Sometimes people who have had the flu say that afterwards they're just not thinking right. My wife always says pregnancy is a great time for brain fog, that she has a great memory, except during the time that she's pregnant. And so it clearly is this mild decrease in performance. Now, the decrease in performance is not a lot, but for people who are used to being at a high level, this brain fog is so annoying. So one of the times we most frequently see it in pediatrics is after concussion. So we see a kid and they've had a concussion, and we ask them sort of simple questions like, take 100, subtract 7, give me the number, subtract 7 again, called 0 sevens. Now, people have not had a concussion. It's like, oh, I know how to do that. The kids who have a concussion is like 3, and then I can't even figure it out. So that kind of brain fog, which you don't really recognize until you ask them, really shows up with this. I have not seen a good study on the brain fog, but you could do it. So for example, we do this test called impact testing on all athletes, or we try, before the school year starts, and you see how well they perform on it. And then they get a concussion, you see how well they perform on it, and the difference is shocking. Now, they recognize a little bit of brain fog, but people around them don't. But when you look at the results of the test, it's like, oh my goodness, you're terrible. We know that, for example, if people take their SATs, get a concussion, and then make the bad decision to take their SATs again, it'll frequently go down 100 or 200 points. So a little hard to check for, but clearly a symptom that we worry about. And one of the things I was going to talk about later, is a good time to talk about it now, is that this is for many people not just, a little flu. For many people, you just can't get over it. But I mean, the president was 3 days in the hospital. Chris Christie was a week in the ICU. So that's more than a little flu that you'll just get over. And we're still seeing lots of symptoms of people way later on. I was talking to someone today whose relative, I can't remember if it was the mom or the sister, still doesn't have their sense of taste back. We've talked about the myocardial injury seen in people who had even mild cases. A study came out from Europe this week that showed that people who had severe COVID, severe enough to be hospitalized, 100% of them had heart disease later on, showing inflammation in the heart. If you do a biopsy, it shows a lot of inflammation going on. They had decreased heart function. Heart function is not good at coming back. So, I mean, there's some things that are actually pretty good at coming back. You can destroy it. You can hurt your liver with drugs or whatever. It regenerates. You can actually do some damage to your kidneys. They tend to regenerate pretty well. Lungs and hearts do not. And that's why the damage that we've seen to hearts and the damage we've seen to lungs actually may be the big, long thing. We may see 10 years from now a lot of people who have entered into congestive heart failure 10 or 20 or 30 years earlier than they would have due to heart damage that they got from COVID. And that's why I think we have to keep the rates of COVID as low as possible. We'll get to that later. This is great. Actually, this is working out better for the questions than before. If someone is exposed directly to a positive sick person and they test negative, is quarantine necessary? So Missy, you'll have to do that. So if someone is exposed directly to a positive sick person and the exposure person tests negative, so if that's the case, so that I've been exposed to someone, I get a test and I'm negative, it's good that I have a negative test, but it doesn't change quarantine at all, because you'd have to test me every day with a perfect test, and there is no perfect test, and you can't really get tested every day. So the only alternative if you've been exposed to a positive sick person is to quarantine. So someone says, I work in close proximity to someone who tested positive for antibodies. Is it beneficial for me to get tested? If you want. If you donate blood, and I donate blood on a very regular basis, they do a COVID antibody test and give you the results. So mine's been negative the 2 times I've donated blood in the last 3 months. It's simple, and my tests have been negative. I'm not sure that antibody tests are very useful, except in the situation where you want to donate, where you've had the disease, you want to donate COVID convalescent plasma. That would be a good time. Or if you were sick during a time where there was no testing available and you want to know if that was COVID, that would be useful. Other than that, antibody tests have not been that useful, and we don't see very many. So Cindy says, do I know what the numbers are for Hawaii? And yes, I know the numbers for Hawaii, if you give me a second here. So Hawaii, as I said, did a very nice job with quarantine. They've been threatening to kind of open up and let people test before they come. I think it's foolish, but they don't ask me. Let's see, so Hawaii has not very many cases. So Hawaii has 14,000 cases, 189 deaths. They have a population of about 1.4 million, so about a third of what Oregon is. So they've got actually a slightly higher case rate, but similar to Oregon, and about the same kind of death rate. So when you look at that, Hawaii has done about as well as Oregon, which is pretty well. Right now, they had 88 cases yesterday, about a third of what we had. So Oregon and Hawaii actually are the two most similar states. So Chelsea says, what is the difference between the rapid test and the one they send to the lab? So there's lots of tests out there, but let me break them down into three major categories. So the three major categories, the first one is the big lab PCR test. This was originally the test that the CDC made, that Quest uses, that LabCorp uses, and these use big, very expensive equipment that only exists in limited places around the country. These use the deep nasopharyngeal swab. I showed a doc how to do one today. You never forget these. These are really distinctly uncomfortable. These go in viral transport media. They get sent to the lab. These are the tests that we think have 100% specificity. There are no false positives, and they have the lowest rate of false negatives. So if there is virus in the sample, they get it almost all the time. Now, the problem is there's not always virus in the sample, right? When you do that deep nasopharyngeal swab, you may not get enough goo. There may not be a high enough viral load to find it, but these are sort of the gold standard tests. These take, since they have to go away somewhere, they take a while to get there. They take 4 to 6 hours to run. Sometimes they need to be run many times, and then you got to get the results. So these are the ones that take a couple of days. There is then the very simple antigen test. So antigen means looking not for the genetic material, but for the protein. And those are things like the Binax that we've talked about, or the Sophia Kydell test, or the BD Veritor test. I think those are the three. And these are looking for antigens. These are rapid. Usually get the results back in less than an hour. And they're pretty accurate. If there is virus there, about 90% of the time you detect it. If there's not virus there, between 90 and 100% of the time you say there's no virus there. So while the other one is nearly 100 and 100, this one is in the 90s and the 90s. So not great for doing like sampling huge populations. Not great for where you need to have a super important decision, like do you put this person in the same room as somebody else with COVID? In that case, you have to be like 100% sure. So they're not good for that, but they're really good for people who are mildly symptomatic who want to get the test, because you get the test results right away. So today in the clinic, I had a kid who came in for a well-child visit, and the mom said, oh, but she's had fever and a cough, and I worry that she might have COVID. Did the Binax test, took 15 minutes, negative result, and that's exactly how they should be used, because there was no way looking at her and looking at her story that I could say to the mom, yeah, she doesn't have it. I could say she probably doesn't have it, because most people who've got a cold and a little bit of fever don't. Well over 90% of the people who have those symptoms don't, but there's about 10% that might, and there's no way for me to look at people and know if they do or not, but this is why the test is so great. And that's what the test. Now, in between the rapid tests that take less than an hour, not that accurate, but you trade speed for accuracy. Then in the middle, there are tests which use what's called isothermal amplification, like the Abbott ID Now or the BioFire. And these are not quite as sophisticated as the ones you send off. These can be done at Mercy, and they can be done in other labs. They are in between. They seem to be a little bit more sensitive, a little more specific than the antigen tests. Not as sensitive as specific the other ones, but a little faster. So you have cheap, fast, not quite as accurate, and expensive, slow, and very accurate, and then all gradations in between. So which test should which person use? A lot of controversy. I was on a 1-hour conference today where people are arguing about that. But I think in the end that those quick tests should be used for mildly symptomatic people. They should not be used for asymptomatic people just screening, like, hey, I want to know what's going on. And they shouldn't be used for people where you're making a really important decision, like quarantining them or cohorting them in the ICU. If you're asymptomatic and you want to know, you should use a PCR test. If you have a super important decision, you should use a PCR test. Long answer. Okay, so can I tell the impact of constant hand sanitizing and wearing masks might have on our bodies, Sandra says. And, there is a concern. There's this hypothesis that goes on called the hygiene hypothesis. And what it shows is that kids who live on farms tend to be pretty healthy. Now, they do get into more accidents than most, and they do seem to get some more parasites than most, but they don't seem to get very much asthma. They don't seem to get very much eczema. They don't seem to get very much fatigue. They tend to get a lot of germs early on in life, so they tend to be resistant to lots of things. So many of our farm kids are pretty darn healthy. And so there's some sense that the normal germs that we're exposed to somehow help our immune system to find out about other things. And again, that's not shocking to me. The question is, if we do a lot of hand sanitizing and wear masks, will that decrease our ability? And I don't think so. Nobody studied this, so I can't tell you for sure. But I think the biggest protection is actually soil organisms. So it's actually digging in the soil that makes you sick, that makes you well, and protects you from sickness, rather than stuff in the air. And so for months now, I've been recommending that people, if they're worried about those things, go out in the garden and dig. One of my favorite things in the whole world is worms, which I can tell you about some other time, but I'm always digging around in my worms, and I think I get exposed to lots of other good germs there. We grow a little garden, and that would be useful. Whether wearing a mask will do this. Now, wearing a mask will protect you from COVID, which I think at this point is a bigger risk than those other things. So Wink says, what are the guidelines for preparing common food at a mask-wearing, socially distanced youth campout? Well, socially distanced, mask-wearing youth campout, it's a very good thing. We don't think that this is foodborne very frequently. We think actually the biggest risk with food is that we tend as people to eat food together. You put 10 people at a picnic bench and you tell stories and whatever. I mean, some of my greatest memories are, sitting at a picnic bench and chewing the fat and talking about stuff like that. So actually food preparation, not such a big deal, but what actually is the place where people are eating. So Veronica says, is it true that antibodies only last about 3 months? So this is very complicated because the system that your body uses is much more complicated than just antibodies, right? You've got antibodies, which are these specific proteins that attack the virus. There's your T cell immunity, which are these cells which recognize things and kind of coordinate the show. And then you've got neutrophils, which are these little, if you remember that little video game Pac-Man, that go ahead and eat the germs once they've been identified. So there's lots of things there. And your antibody system is amazing. So if I got a hepatitis B vaccine, I'd have an increase in my antibodies, and then those antibodies would go really low. But my body would remember how to make them so that if I got exposed to the hepatitis B virus again, those antibodies would come up in the space of just a few days, and they would be tremendous numbers of antibodies that would help to fight the infection. So that when you look at the antibody levels and the antibody levels go down, we don't really know. Now, the things that we know the best about are bloodborne disease, so hepatitis B, a bloodborne disease, or measles, which is a respiratory disease, but then becomes, you get viremia, so you have it in the bloodstream. This is a funny one. I looked yesterday to see if they've ever been able to culture virus out of someone's blood, and they haven't. They've occasionally been able to find RNA, but they're not able to find virus. So the thought is this doesn't really get into the bloodstream. And since it doesn't really get into the bloodstream, we're not sure how well the IgG antibodies, which are only in the bloodstream, work for this. And so the whole deal with antibodies is really unclear. Now, if we knew, and this goes back to the herd immunity thing, which I'll talk about later, if we knew that the antibodies you got for this were long-lasting and protective, it would make the discussion on herd immunity a little more logical. But since we don't know whether the antibodies are either protective nor long-lasting, the idea to kind of let this just burn through the population and let people build up immunity is really troublesome, I think. And that's why this Great Barrington Declaration is just has me gobsmacked. Okay, So Alicia says if a person tests positive, then goes back a week later to see if they still have COVID and test positive, is it counted twice? We look at the test, but it only gets counted as one positive person. And so when you look at our cases are people rather than positive tests. Very frequently, people have 2 or 3 tests. So we had this one guy who got tested. I don't believe it. I want to get tested again. Got positive. So I still don't believe it. I want a 3rd test. I got a 3rd test. So he had 3 positive tests, but he only got counted 1 time. And so it only gets counted 1 time. Now we do know that people will sometimes test positive for a long time. Again, I tried to find what's the latest time that people can actually be contagious. We can't find any things where people who are not desperately ill have transmitted after the 10th day. There are some studies that people are really ill in the hospital, intubated, can still have some live virus at 20 days, but not past 20 days. So that's why our isolation periods are 10 days for most people, and 20 days for people who are hospitalized. So Zay, and I got this right this time, it's Zay, right, not Zach. Does gut health make a difference with COVID? We don't know. Now, we do know that this is a gut disease. So we clearly know in this disease that it's in the gut. In fact, we know it's in the gut because you can find it in sewage. And a lot of people have a lot of GI symptoms. Actually, when we checked in the people, the long haulers, GI symptoms were fairly common. So, and does gut health make a difference? Again, I don't know. Again, gut health means that things just flow through, that you can eat well, that you have normal poops, everything works well. In our society, we do things that really damage our gut health. Taking oral antibiotics really makes a problem because it kills off many of the bacteria, but lets other ones survive. Eating a lot of processed foods is probably not as good for our gut as we would otherwise do. And so you would think good gut health would make a difference, but I could not find a study about that. So Lori says, my daughter is a college athlete in another state and tested positive. I'm very sorry to hear that. What type of health screenings, if any, should she have in the future to check for long-term damage? Well, the NCAA recommends, so the National Collegiate Athletic Association that takes care of Division I athletes, and the American Academy of Pediatrics, which is the group of pediatricians, recommend that they have an evaluation by a specialty cardiologist before they return to play. And that might include an echocardiogram, it might include an EKG. In fact, it might even include a cardiac MRI, because this inflammation in the heart shows up actually far and away best on a cardiac MRI. So Danielle says, what are the differences in symptoms of those who have mild symptoms and moderate severe symptoms? And so mild symptoms could be fever, cough, loss of sense of smell or taste, diarrhea, abdominal pain, these COVID toes and whatever. We usually judge severity on the need for oxygen. And typically, if you need oxygen, it's considered moderate. If you needed assisted ventilation, it's considered severe. And this is why there was this questions about the president, whether he had moderate or severe disease. He clearly was past the mild, needing to be hospitalized and needing oxygen. So that's it. So mild, typically not admitted, moderate, admitted, oxygen, but no ventilation, severe, ICU, requiring assisted ventilation. So Kat says, if it doesn't get in the blood, what causes the clotting issue? It's a great question. We think actually, the clotting system is another incredibly complicated system where the body recognizes an insult to the system, sends out messages to the clotting system to start getting active. And we don't actually know how, if it doesn't get in the blood, it makes those messages. Now, there's lots of messages out there, things called cytokines and interleukins, that tell other parts of the body to respond to the inflammation. So again, using the crude analogy of like a house, it basically is the alarm system telling to lock the doors or close the windows or shut the fire dampers. But how this all works, we don't know. So there was actually a lot of hope that medicine called tocilizumab, they make these impossible to say, also called Actemra, which is an interleukin-6 inhibitor, would work because it would tamp down those signals. A small study suggested it did not work. So Crystal says, how long does the average person take to show symptoms after exposure? I know it can take up to 14 days, but what's the average? So they've done some elegant studies in places where people were fairly isolated. The typical time is 5 point something days. When we look, it's really 5 or 6 days. We so rarely see somebody after 10 days and so rarely see anybody less than 3 days. It really seems to be 5 or 6 days after exposure. Now, some of the trouble, unfortunately, is that in many of these events, they are not one single hour event. You know, when grandma comes to visit, she comes to visit for the weekend. And so it's a little hard to know whether you got infected on Friday night, Saturday, or Sunday. But in areas where there's relatively short, 5 or 6 days seems to be the time. So Chelsea says, what are the common symptoms in children? They're like adults. They're fever, cough, runny nose, and sore throat. However, as a pediatrician, like every kid's got those. So is there anything special? No, and that's why when this kid was in the office today and she had a runny nose and her mom said she had a little bit of fever and a little bit of cough, there was no way I could say you had COVID or you didn't, right? Because some people don't have any symptoms. So that's why you need to do the test. And that's why it's going to be so great to have these new tests. They're so easy to use. I've already done a bunch of them. Even I can do them. They're that simple. Okay, let me go through some other things. So, yeah, 100% of the severely ill had heart disease. And, you know, if even 10% of those go on to get congestive heart failure early, that may be one of the worst parts of this whole pandemic, because congestive heart failure is a terrible chronic disease. Monoclonal antibodies. So these are the things that Regeneron and Eli Lilly are making that the president said was a cure. Studies haven't shown that yet, but they've only been tested on a couple of hundred people. They really haven't been tested widely. The Eli Lilly, which has probably the best manufacturing thing, is paused their trial because of a side effect, and don't know what that's all about. And so while they may be promising, they are only available under very special circumstances, like if you're the president, and they are not widely available to any of the doctors here in Oregon. Remdesivir, a big study came out from the World Health Organization. It did not show much benefit of remdesivir. Now, in the U.S., there have been a couple of good trials that showed it shortened the length of stay, which is always a good thing. Nobody wants to be in the hospital. And maybe increased mortality, but not reliably. The other thing I want to talk about, you'll hear, is this herd immunity thing called the Great Barrington group. So Great Barrington, if you've ever been back east, is this cute little town in southwestern Massachusetts. It's up in the Berkshires, which is a little away from where I went to school. But it used to be a place that we would sometimes go skiing. And so, you know, Great Barrington is this little town, and the American Institute for Economic Research, a libertarian think group, got together and put together the Great Barrington Doctrine, which says that we should stop doing all this stuff. We should just let this disease go through the community, develop herd immunity, and we should try as best we can to protect our seniors and leave it at that. I don't know. It really discounts how important deaths of seniors are. You know, it basically suggests that we'll get rid of the old dead wood here, and then, you know, this will be somehow good for us in the long term. That to me is horrific. You know, when I look at the people here in the town that are admitted to the hospital, many of them are in their 60s, and our very sickest patient, who ultimately recovered, was in his 40s. So yes, old people are affected, but there are a lot of otherwise relatively young and healthy people who are affected. The second is, it says, well, you could easily protect the seniors. And we don't see this, and can't find any place in the world that has been able to do this and protect the seniors. People bring up Sweden, but again, Sweden's got a lot of cases and a lot of deaths, and a lot more deaths and a lot more cases than Norway and Finland right to the side of them. So I'm not sure that's a great model. And in the United States, where the people who work in nursing homes are mostly poor people, don't get paid a lot of money. They're working in these nursing homes, many young people. They're going to bring it home. And in the U.S., we have many multi-generational families, either by design or because the parents aren't around and the grandparents are taking care of the kids. And so the sense that you could protect the grandparents, how do you protect the grandparents when the kids are going to school? How do you protect the grandparents when there's a 4-generation family in the house? So I just don't get this. There was an excellent editorial written by a guy named John Barry that said, yes, you could do this, but it's going to cause a lot of deaths. So look up John Barry, New York Times. He wrote really a convincing thing. John Barry is really one of my heroes. He wrote many years ago a book called The Great Influenza, which is probably the best history of the 1918 influenza. And it's pretty horrifying. And his prediction was that we had this in 1918. We will get some kind of pandemic like this again. And so his predictions did come true, and his thought on this strategy is important. So Jamie says, does a COVID fever typically not respond to a fever reducing medication like Tylenol? That's not been the analysis. Actually, the analysis has been that Tylenol or other NSAIDs really provide a lot of relief, not only from the fever, but from the achiness that you get with this. There was early on one paper that suggested that nonsteroidal anti-inflammatory drugs may have a negative effect on the impact of the disease. That's not been repeated. So Amy says, if we let herd immunity happen, what would happen at a local level to our hospital? So can't tell you for sure because no place has tried this herd immunity strategy, although there are other places in the country that have done very little restrictions. And so it's not exactly a herd immunity strategy, but it's pretty close. So, in the past we've done this doppelganger analysis and looked at Twin Falls and Rapid City, South Dakota. So we're feeling overwhelmed now. We're having 3 or 4 cases a day on average. So we have 3 or 4 cases a day. We're running like crazy to track everyone down and keep everybody safe and whatever. We have 3 or 4 people in the hospital. Twin Falls has 87 per 100,000. So that would be like us having 100 cases every single day. If we had 100 cases every single day at our current rate, we would have 10 hospitalizations a day. Average hospitalization is 6 days, so there would be 60 people at Mercy every day. And when I went through the newspapers in these areas, this is what they're having. They're having 20, 30, 40, 50 people a day in their hospitals. And that's what it would look like. And I think if we had 30, 40, 50 people a day in the hospital, we would no longer be able to do elective surgeries. If you had that many people in the hospital, people would be worried about getting this disease at the hospital. And so, yes, you could do that. And you'd have some deaths. Most of the deaths would be in older people. And we would then have the death kind of rates like we would see in Georgia, where in a similar sized county, you'd have 80 or 100 deaths. And this would go on. So this herd immunity thing, nobody thinks you'd build the herd immunity until June. So between now and June, you'd have 60 or 80 people in the hospital. You'd have a couple of deaths every week. You'd eventually wind up with, in Douglas County, a couple of 100 deaths, a couple of 100 hospitalizations. And then if immunity was long-lasting and protective, and remember, no one has shown that the immunity is either long-lasting or protective. But if you were lucky and it was long-lasting or protective, then the disease would sort of die out over the summer and end sometime this year. That to me strikes me as really, really not very smart, because had we done this before, we would not have had the benefit of the monoclonal antibodies or what we know about prone positioning or time to rebuild our PPE stores or progress on a vaccine. So the longer we can kind of delay the overwhelming, the better off we'll be. I mean, the hope would be we could develop an antiviral, and there's 40 that are out there, that really would be effective as antibiotics were for pneumococcal pneumonia. So some of the amazing stories are when penicillin came out, it was incredible, right? People were dying of meningitis. You give them this and they would come back to life. People were dying of pneumonia. You give them this, they effervesce and they would be back to normal. And so, so that's why I think this herd immunity strategy is a risky strategy. Imagine if you did this and then found out that you didn't have long lasting immunity, then you would be next spring with a zillion cases, and you'd be facing this for time. You'd face this until we had something, either a better therapeutic or that. So Veronica says, it was posted that Walmart in Coos Bay had an outbreak. Why can't we know what restaurant has had the outbreak locally? Well, you can, and it may get reported. So the reporting stuff in Oregon is that if you have more than 30 employees, it gets reported. Walmart presumably has more than 30 employees. If you have less than 30 employees, that these outbreaks are reported differently. This restaurant that we have locally has less than 30 employees. Now they're closed, so there's no risk to the population at this point. And so just the rules, and we follow the rules exactly. Okay, a couple of the things that we had here. Again, lots of disease in mink. And so when we look at spread, it's pretty clear that this disease spreads from people to cats, from people to big cats, tigers and lions, and from people to mink. We can't really find a case where it spread from big animals to people, maybe a case or two where it spread from cats to people, and maybe some cases where it spread from people to mink, and then mink back to people. So this will make this much harder if, for example, there are wild animal populations that can carry this, because then the concern would be, yeah, you could immunize all of the people, but you're certainly not going to immunize all the squirrels if, for example, squirrels would be the person. So Sandra says, if this virus spreads like the flu, does this mean that we're all going to be exposed eventually? No. Yeah, if we did nothing else, right? If we did nothing else and just let this disease pass, it presumably would spread to almost all of us. But no, we can clearly keep this down. Now, we haven't done this, and people say, well, why didn't you do this in the past with the flu? Well, because flu has a very low death rate overall, and there are some effective things for flu, like flu shots, which are very good, and we're doing flu shots this Saturday in Drain, and on Friday I'll get you the details. On Friday the 30th from 10 to 2 at the fairgrounds, and on November 11th from 10 to 2 at the fairgrounds. But flu in general, there's an effective vaccine, there's a great test, and it's been a great test for a long time, and there's a very effective antiviral drug, which is Tamiflu, and that's why we haven't done all the other shutterings or whatever. However, flu is an important thing, and I look back over the last 5 years, I've given at least 20 interviews about how important flu is and how important it is for people to stay home when they're sick and get a flu shot. So, flu is important, but flu kills a lot less people. Now, again, I'll get a lot of crap about that. Oh, they said it kills 60 to 80,000 a year, and it does, because what we're looking at is excess deaths during that time. If you look at the same model for COVID, it's a lot more than the 225 that we've already noted. It's maybe double that for these excess deaths that we just don't know where they're coming from. So if you're gonna measure these together, COVID is so much worse than the flu. Even during the worst flu pandemic, there were half a dozen people in the hospital, 1 or 2 in the ICU. not like this where you could have dozens of people in the hospital at any one time. Okay, well, I think that about does it. That was actually a pretty good way to do questions. I hope my looking away was not problematic. Again, so the cameraman's coming in the room here, so we'll go ahead and put back my mask. Again, this is Dr. Bob Dannenhoffer, the Public Health Officer from Douglas County. Be safe and be kind. Thank you.